This conference will now be recorded.
Good evening, everybody. I'm John. I'm going to moderate tonight's AnCan High Risk Advanced Metastatic Prostate Cancer discussion group for May 12th, 2026, backed up by Len and Rick. We'll be recording tonight's session. We will discuss a lot of things, exchange a lot of ideas, but we will not be giving medical information. So you'll take anything you hear back to your medical team to discuss. We want to thank Helix and Blue Earth Diagnostics, as well as Foundation Medicine and Novartis for helping to support us in this group. And we do have a newcomer in the group, so I'm going to just get myself a blank card out and start down the list. I've already gotten his permission to take his information. His name is Steve, E-N-N-E-N, right?
A-N at the end.
A-N, okay. How old are you, Steve?
56.
Oh, young guy. We've got a special group for men in their 50s, by the way.
I did attend one of their meetings last month and then just got caught up with life and haven't made it back since.
Okay, very good. Where do you live?
I live in Alpharetta, Georgia, and suburb of Atlanta.
Tell us how you got, tell us about how you got diagnosed and when it was.
A year ago, I had a TURP-like procedure called aquablation.
This conference will now be recorded.
Okay, sorry, go ahead. So you had an aquablation for what?
For
lower
benign
urinary tract symptoms? Yeah.
Yep, I was having pee issues. And so they, very successful. I can pee like a racehorse now, but they tested the tissue and it came back positive. The Gleason score was a 4+5 or a 5+4. Then I had a PET scan MRI, which showed that it had spread, lymph node, a little bit on a rib, a little bit on a lung. That was, last April, a year ago.
Okay, and when you said you were a 4+5 or a 5+4, they've got to call it one way or the other. What did they call it?
Oh, I just didn't know the order of the numbers, but I know it's added to a 9. But
okay,
I've got the pathology report, but I don't want to slow things down by trying to look through it if it doesn't matter too much to you, or I could follow up after if it's meaningful.
Okay, it's not a hugely meaningful difference because both are in the very high risk category by NCCN standards. So you have metastatic prostate cancer, and actually, for next time you come, if you come back, do bring your pathology report. Okay, I think we would like to see if there's any details in it to influence how aggressive your treatment's going to be, although it's probably going to be pretty active since you're metastatic. So what happened since April of 2025?
Well, one process question. So if I have my pathology, but is that something I can upload in here, or do I send that outside this?
You can send it to me. Maybe Rick will put, or David will put in my email address.
Okay, that would be great. I'll continue.
Okay, so you got the PET scan in April of 2025, right?
That is correct.
Right. Okay, so then what happened?
So saw a couple different specialists. Ended up working with Emory. My doctor's Dr. Jamie Goldman, and they put me on Nubeqa and Orgovix. And then I began 6 infusions of it begins with a D, but now it's escaping me pretty.
Docetaxel?
Yes, exactly. So I did that over the course of last summer, finished up the last infusion in early September, and then I've continued with the 2 oral meds since then.
And after you got this triple therapy, what happened to your PSA? What was it to start with, and what happened later?
Well, that was a little bit unusual from what I've been told. Is my PSA a year in April of 2024 was a 2. And then I had the procedure, so I never was alerted based on high PSA. So it spiked, which they attributed to the procedure itself, but then very quickly decreased, and now it's 0.05, I think.
0.05. Okay, and that's a year after your treatment started. You got down to 0.05.
Correct.
Right? Okay.
Yeah, very early in the treatment, it was down at around 0.2, and then it slowly decreased from there.
Okay, and you haven't had any radiation, right?
That is correct.
Okay. And did you have any more PET scans after that initial one, once you got your treatment?
I did. Yes. So I had the initial PET scan in April, and then I had a follow-up last fall after my treatment concluded. And I think I have that as well. Yeah, it showed essential dormancy. I'm not sure of the terminology, but things were pretty quiet.
All your metastases went quiet after your treatment?
Think so.
Okay.
Yeah.
Let's make sure. Maybe you could send that too.
Happy to.
Okay, so you appear at this stage to be having an excellent response to quite an active disease. So your PSA was 2 before the procedure. It spiked a little bit after the procedure, of course. So 2 was the highest your PSA ever got, right? Okay. And so Dr. Goldman, is that a oncologist?
Yes.
Is it a GU oncologist? Genitourinary specialist? Prostate cancer
John,
specialist?
can we clarify? Is he a medical oncologist, I think is what you want to ask.
I'm not sure how to answer that. It's a she, actually, but.
Okay.
So she might be a radiation oncologist, but probably not, because you didn't get radiation therapy.
Yeah, I don't think.
She'd be a medical oncologist prescribing all this treatment, and maybe even a prostate or GU specialist medical oncologist. We don't know.
Yeah, I just Googled her. Jamie practices general medical oncology and hematology with a focus on treating patients with genitourinary cancer at Emory John Creek.
Okay, so it sounds like she either has a special interest or an actual formal practice in genitourinary medical oncology. And she's certainly up to date on her thinking in terms of your scanning and in terms of the possibility of 3 drugs and all that. Did she order any genetic testing for you?
She did, and I probably won't be able to answer this very well, but I was told that it was nothing that I needed to worry about from a family standpoint. So I assume that meant negative on that, if that's the right way to describe it.
Yeah.
But I also have that report as well. I could email that to you.
Okay. There's 2 ways to test your genes. One is to get a saliva or blood sample and check the kind of genes that run through your family, and that was negative. You can also test the genes on your biopsy sample. As far as you know, that probably wasn't done, right?
I do not think so.
Okay. Any family history of cancer?
No.
Are you a veteran?
Nope.
Okay, and what's your living situation?
Married, two kids, 20 and 18. And when I received this diagnosis, I essentially retired. So I'm able to focus almost exclusively on exercise and healthy eating and quality of life.
Good. So you're doing all those things already?
Pretty aggressively, yes.
Okay. And what got you to seek us out at this particular time?
Well, I had found a support group in Canada from reading it in my news feed, and then they mentioned that there was one here in the US. So I found that it was useful and interesting. I wanted to acknowledge the weekly emails that I get, which I read diligently, and I've watched some of the other casts. So I really appreciate gaining some insight. I had kind of been going through this as well. It is what it is, and my doctor seems to know what they're doing, and I verified through someone at Johns Hopkins that the triplet seemed like the right procedure or the right drug protocol. So I've been pretty passive in the process. So I thought I would just try to educate myself, and I realized listening in on one of these that how uneducated I am about some of the details of my own situation. So that's kind of my motivation, is to learn, which I do a lot from just reading your emails. I appreciate that, Rick.
Well, great. That's down to Rick, who's in the house here. He writes those incredible emails every week, full of great information and links and things like that. So you already know that we have an under 50s group. We also have a men's discussion group to focus on emotions, feelings, called Men Speaking Freely. Okay, so at this particular point, how are you doing with your Orgovyx and darolutamide? You've got a PSA of 0.05. It'd be nice if you got to undetectable, but you're pretty darn close to undetectable. And you appear healthy, so you don't seem very sick from your treatment. It's going well?
Yes, I would say so. A few little lingering, I've got some bags under my eyes, and, it's still a little bit of unhealthiness. I would say eyebrows are a little thin from the infusions, but other than a little fatigue, I'd say, I operate about 90%. So I generally get my exercise in the morning before I get tired, and then kind of do what I feel comfortable doing the rest of the day. So yeah, no significant side effects. A little bit of hot flashes, but very manageable.
Just a few hot flashes?
Yeah, occasional.
Okay.
But yeah.
And are you, so you got two children that are almost adults, so you're probably not thinking about more children, right?
No, that is
okay.
Not relevant.
Okay.
I
Just,
appreciate you asking.
some of our guys are actually young enough to have to consider future fertility in the equation.
Yeah.
Now, your plan going forward, what's that?
Well, the impression I got was stay on the two oral meds until they stop working, but I'm not sure that I'm 100%. I'd like to be aware if there are other options I should be considering. But right now it seems to be working quite well.
And how often are you going to get a PSA?
I go quarterly.
Okay.
To get the PSA and then meet with either the Dr. Goldman or one of her PAs or whatever they're called.
Okay. Great.
Good. Thank you.
Questions for us?
Not at this time.
Almost everybody in this room has been in close to your spot. Any comments from anybody to get Steve going on his second year?
So yeah, I have a couple of things I'd like to bring up, and then we have a couple of hands up too. So whilst you guys are getting your hands up, there are two things I think that I would raise with Dr. Goldman. The first, which bothers me, and it actually came up in an NCCN webinar today, on a study called TAPUR, T-A-P-U-R, which the doctors in the room are going to be very familiar with. And by the way, Scott Brennan, it's kind of the grandfather of the guns trial. It was one of the very first trials to look at mutations in a basket. In fact, it was the first trial. I think it dates back to 2014. And they have an annual webinar, and the guy, Shilsky, who was the PI, was speaking. The NCCN guidelines clearly state that if you are metastatic, you need a somatic test of your tumor, not just to see if you inherited a gene, but you should get a test to see if you've made any mutations yourself. Because if you have made mutations yourself, there is a possibility that you might set up for a drug, a precision drug. So, and as the months go by and we get more and more approvals, there are more and more options. And for example, the one that's on the radar of a couple of our guys here is a drug called capivasertib. Commercial name is TrueCap. And if you happen to have certain mutations, you could be a candidate for that drug, even early on. But we don't know if you don't get tested. And the problem is that the compliance with testing is very, very poor. And there have been a whole number of studies on this, and it just beats me where you get a doc who's a GU doc, should be familiar with the guidelines, advertises herself as a GU doc, but doesn't run a somatic test because she feels that triplet is the right. Triplet means an ADT drug, Orgovix, and a secondary drug, darolutamide, and chemo. That's the right way to go. And she's not wrong. It is the right way to go, but there may be a better way to go, and she won't know that until she gets a somatic test. So the first thing I would do if I was in your shoes is ask your doc, I want a somatic test. Don't ask her, do you think I need a somatic test? You say, I want a somatic test because I know that I'm metastatic and the guidelines call for it, and I'd like to know what somatic changes I have. Now, just because you have them today may not be the same 3 years from now, because we have to keep looking, because you didn't inherit this, so it isn't there for good. And you can have, Len, bless him, had a BRCA mutation early on, but he doesn't have that BRCA mutation now. But when he had that BRCA mutation, he might have been eligible for the drug. And that's why we need to know it at the time, and we have to keep retesting. That's the first thing. Second thing is we have seen good results debulking the primary tumor. That means taking the tumor, the prostate cancer, the cancer out of the prostate. And that's generally, it can be done with surgery or it can be done with radiation. We feel that the radiation has lesser side effects, but it is a discussion. And you should certainly be having that discussion with your, with Dr. Goldman and asking her whether she thinks you are a good candidate. And if she does not, I may not be satisfied with that, and we may recommend you get a second opinion with a really solid GUMO who maybe understands the issues better. So those are the two things, somatic test and debulking.
Okay. I did ask a number of times about the debulking concept because intuitively it seemed, well, it's prostate cancer. Why wouldn't you kill the mother ship? And she said, well, the standard of care is that a surgery can be so intrusive and that it's just not viewed as being sufficiently beneficial for what you would go through. And the analogy she provided to me was that the seedlings are out and sort of independent in the rib and the lungs and the lymph nodes,
Right.
and that they're on their own now. So that was the way it was described to
So
me.
she's correct. And in the past, and I would say 15 years ago, that was definitely the thinking. We would never do this. But starting, there were a couple of hospitals that started to do it more prevalently: Memorial Sloan Kettering and Mayo. Mayo more with surgery, MSKCC a little bit with surgery, but also with radiation. And a lot of people have now moved to doing this with radiation. And what we've seen is that there is an advantage. The trials show that there is an advantage. I wouldn't, if it were me, I'd never do it with surgery, but I would consider doing it with radiation. And we've had a number of guys who have done it. And if you feel like you do want to get another opinion, tell us, and we can suggest a couple of docs in your area, rough area, that we could send you to in different places, and at Duke or at Hopkins. I'm trying to think about sort of relatively close to where you live. Can't think of anybody else in Georgia, but yeah, we would suggest getting a second opinion, because we've just seen that we've seen people. Guys, how many people in this room, if you can put your hand up, have had debulking, have had radiation subsequently? Steve L is one. Well, we'll let them talk, but let's move it into everybody else, John.
Okay. I appreciate the time, gentlemen.
Julian?
Just a couple of questions from my journey. Are you staying hydrated?
Yes. Yep.
And you said you're exercising every day, right?
Pretty much. Yeah. 5-6 days.
Okay. Did they ever do a second opinion on your biopsy?
Not that I know of. I never requested one.
Your testosterone levels, have you ever measured them?
That's part of the blood work, and I think it flattens out at below 20, whatever the measurement is.
Yeah, I was on the same drugs you are, and it's yet to come back up. So, I'm not sure if there's much hope there, but other men on this group may say something about that. But it's a long journey back to get that testosterone back up. That's all I had.
But isn't the drug purposefully keeping the testosterone down? Isn't that what it
Yes,
was?
it is.
Yeah.
Julian is actually thinking way ahead. So
Yeah, I'm sorry.
maybe a possible time a couple of years from now, when you have long been in remission and no recurrence has occurred, and you might even be able to get off your medications for a while and bounce your testosterone back.
Oh,
So having a baseline, as Julian suggests, is a great idea, because you got something to compare it to and something to help you predict what it might be like when you go off, when and if you go off your meds.
I see. Thank you.
Thank you, Julian and Rick. How about Pierre? Yeah. Okay, let's go to Sam. Sam, can you unmute and tell us what your hand is up
Sorry.
for? Sam? Pierre? Okay. No, nobody there. So you got some really good ideas going forward. Somatic testing, a good discussion about debulking. You got your PSAs. We talked about the possibility of a second opinion. Your side effects from ADT sound like they're mild enough to not consider a switch about that. I don't know if Rich has a comment about that, but I think that's I think that's good. Well, welcome to group. We meet on Mondays and Tuesdays, different days of the week. So don't come in next Tuesday at 6 p.m. Eastern. We're meeting next week on Monday at 8 p.m. Eastern.
Right. And Steve, don't forget, we have an under 60s group this week on Thursday. And we got some really good guys coming into that under 60s group. And Bill Franklin leads it, and the discussions are really great. I think that you really add to it because there's a few guys in there who would like to talk to you about retiring. I'm sure, because it's going through their mind too, you know, and that's why we have that group, because we don't really want to talk about this in here, but in that group, yes, it's a really, really solid discussion, and there are even a couple of guys sitting here in the room right now who attend that group beyond you. So we'd love to see you in that group on 8 o'clock. We've moved the time now to 8 o'clock. Makes it easier in this room on Thursday.
That's a monthly group, correct?
That's a monthly group.
Okay.
Until the guys all come together and say we want it more than once a month, and then we'll do it for you.
Great. Okay. Thanks, Rick.
John, you might want to check with Leon Roberts in case he's new and if he's gotten his microphone working. Are you there, Leon?
Yes, I'm here, guys. How y'all doing?
We're doing. How are you doing?
I'm doing great. I've been going in and out trying to get on. I haven't been successful at all on the camera side, but I see I've got the mic side working, so that's good as far as verbaling. So that's great. Good to be on board and listening to some of the information that I'm in experiencing also. But it all sounds good to me. I'm in sync with where we are.
Are you new to this group, Leon? Have you been with us before?
No, I have. I tried to get in once before, three times, but I wasn't able to do anything. This is the first time.
Okay. Well, we're gonna pass you over to Dr. John, and we'll go through to learn a little bit about you.
Okay.
How old are you, Leon?
I'm 83.
And where do you live?
I live in Austin, Texas.
And what's your living situation?
As far as
Are you living alone? Are you living with family? Social support?
And living with wife here, with us two. Everybody else is gone, grown and gone.
Tell us, when did you get diagnosed, Leon?
Oh my goodness! I started this PSA thing back in 2007, I think, around about that time. So it's been a long journey regarding waiting, watch for waiting, when nothing happening, watch for waiting, nothing happening. All of a sudden it started to move.
When was that it started to move?
Let me see here. Back in my memory, I think maybe about 2018 or so. Yeah, maybe around 2018, it started fluctuating a point here, to point 5, and then 1, and then 2, and so forth. So very slow in increasing. However, it got to a point, got up to 7, and it went down to 4, and said, well, let's do something.
What did you do?
We went and had I got radiation back in 22.
But that's 4 years after your recurrence.
Yeah.
During that 4 years, were you treated?
Still on the watch for waiting list. I wasn't treated for anything. I wasn't on any type of medication or whatever have you.
Okay.
Just real strange the way it happened, but I wasn't on any type of medication.
So 2022, what's your PSA up to by 2022?
Let's see. In 2022, it had gone up to 7, but as I said, in 20, to 7, and we decided to take some action.
And that was radiation?
That was the radiation. Yeah, that was the radiation. And I went through that, and all well and good. And lo and behold, 4 years later, decided to want to ease back.
Now, when you say all well and good, do you mean your PSA went down?
Yeah, yeah.
To what?
The PSA, it went down to, it's down to 0. It's down to point 0.29 is where we are today so far.
0.029?
Yeah, that's where we are today. However,
All right. And what kind of radiation did you get? Was it all in your pelvis? Was it all aimed at your prostate? Were there any other there?
prostate, yeah, through the prostate.
And the cancer hadn't spread anywhere. Huh?
No. It's still within the prostate, and I have graduated up to last December of 2025. I had that shot of Lupron, and so in June they've got me figured out to begin on Orgovix.
Why?
And Exant, and let me see, Elgovix and Exanti in June. That'll be my 6-month anniversary of the Lupron, and to that.
And are you switching drugs in June because of side effects to the Lupron, or because your PSA is getting out of hand again?
No, they tell me that the Orgovix and this Exanti is a little better than the Lupron shot.
So your PSA it's still down low, like
Yes,
0.029.
Yes. I'll know.
Okay.
I'll know next month, just exactly, because before I start on any other medication, I will have I will have an exam.
Okay.
So, an appointment, and then we'll start that. I think the anniversary date, something like June 14. To
Now,
start.
did anybody do any PET scans, MRI
Yes,
scans?
I've had the PET scan and the biopsies and all of that, and everything is still within the prostate. There's been no movement, so they keep.
When was your last PET scan?
Let me see. This is I was just here about that's the wrong folder. I got so many folders. Folders for this doctor and that doctor.
Sounds like it was in late 2025, huh?
Yeah, that's what I was looking at. Can I find my note here? CAT scan, February, that was 26. That was
All
something.
right. And there's no prostate cancer anywhere except in your prostate.
Other than that's it. It's there. Nowhere else.
But it did occur in your prostate. I mean, your PET scan showed active cancer in the original gland. Okay.
On the original plan, yeah.
Okay.
So I'm doing real good, but we're keeping a close eye, because my biopsy was on 12/12/25 on it, and say, well, we're going to work with that.
What did it show? Your biopsy?
That's what I'm looking for. Something like a 4.2. It came up to a total of 6 for Gleason.
Gleason 6?
Yeah. So they work with that, and okay, December.
So you say a Gleason 6, Leon. Was there a 4 in there? Was it a 4 plus something?
On one side, yeah, all on the same side.
Okay, so let me ask you, where are you? Who is looking after you? Where are you being treated?
I'm being treated by Baylor, Scott, and White through the VA.
Through the VA.
Yeah.
Okay.
Yeah.
Well, first of all, as a veteran, we'd love to. Jim Marshall. What am I saying this for? Come on in, Jim Marshall, and talk to your buddy here.
Okay. Yes, sir. You are a veteran, and possibly it could be a service connected disease. So we need to explore it. So if you could put your email address within the chat,
Okay.
I will get a hold of you.
Oh, that's great, Jim. Let me go to the chat. Oh, let me see chat.
Okay, well, not how here. You can finish up, and then there's lots of time.
Yeah.
Okay.
So and we'll and Jim, put veterans at AnCan.org in there. And so the first thing we want to do is we want to make sure that you're getting the right care and the and you're getting all of your benefits. Second thing, is the doctor that you're seeing a medical oncologist, a radiation oncologist, or a urologist?
Medical oncologist.
Okay.
And your medical urologist. I'm done with the radiation oncologist.
Okay. And again, the same question we asked Steve. Do we know if he has a specialty in prostate cancer? It doesn't sound to me like he does from what you've been telling us. Do you know? Or is he just a general medical oncologist?
Well, I think since
Well, let me tell you why I'm asking you this question.
Okay.
Our experience in Austin as to the level and quality of prostate cancer care has not been good. So generally what we do is we send the person to for care either in Dallas or in Houston. Now, we had a guy a little while back who came in and really was adamant about staying in Austin, and I did some research, and there is one doctor in Austin who seems to be pretty well qualified as a genitourinary medical oncologist, a medical oncologist who specializes in prostate cancer.
Okay.
His name is Dr. Michael Latenzi. I've put it in the chat, and he's at Texas Oncology, which is, I think, the other big group in Austin. Now, Jim Marshall can work with you and help you to figure out how we can get a consult through the VA with Dr. Latenzi, who is definitely a prostate cancer specialist, as opposed to the guy at Baylor and whatever it is that you're seeing right now. So, Jim Marshall, you'll see that link that I put in for Latenzi, so you might just want to make a note of that. And Leon, come into our next veterans group, which is going to be on the 19th, Tuesday the 19th of, which is next Tuesday, a week from today. It's not in this room, it's in our other room, our other virtual room, the Schmier room, and you come into that and Jim will work with you, or reach out to Jim beforehand at veterans@ancan.org.
Okay, good. I'm looking for the info. I don't see a chat on my screen here. So
up at the top of your screen on the right, there's two little overlapping boxes.
Next to the 41, you see at the top of the screen where it says 41 by the little guy?
Oh boy.
Right at the top of your screen, at the very top.
Yes,
there's going to be a
little guy. Yeah.
And next to the 41 are two squares overlapping. Click on that, and
Gotcha.
that'll open the chat window for you.
Gotcha. All right. Good.
Leon, did anybody do any genetic testing with you?
Oh, yes, I've had that done. Yes.
Tell us about it.
And the only thing they found was that I do have a carrier of sickle cell trait.
Sickle cell.
Sickle cell trait. Other than that, nothing.
Okay.
Yeah, so no spread of the family. So that was good. They did do that. Yes.
Okay, but that sickle cell trait is a biggie, though, and you need to make sure your kids all know about that and they test for it.
Oh yeah, we do. We did do that after that came up. Yes.
Okay, and what they also need to be aware of is that we used to run a group for a cancer that's highly tied into sickle cell trait, which is called renal medullary carcinoma. And it's a really nasty cancer. And if they have any issues with their urinary tract or their kidneys, or they see blood in their urine, they need to be talking to the doc and getting tested for their sickle cell and talking about RMC. We can help you and send you to the right people, but it's not very well recognized and people find it too late. So I just want to give you a heads up on that RMC.
Okay, good.
Okay, very important. And I'm glad you mentioned it. Will also, Leon, are you signed up to get our reminders?
Yes, that's I saw the email. That's why I clicked in. Yeah, I do get the emails.
Okay, well, we'll make sure that you are on. We've also got a group for people with inherited mutations, and we'll make sure you're on that as well.
Okay.
Leon, you're 83 and about to start on abiraterone. So tell us about your
enzalutamide, John.
Oh, Enza? Okay, tell us about your medical history. Are you is your heart good? Your blood pressure? Any diabetes?
Yeah, I'm on that. I'm on blood pressure medication. My heart's good. I'm all checked out. I'm pretty good shape for an old man. Pretty good shape.
Okay. Okay.
Yeah.
I'd like to open it up for anybody that would like to talk to Leon, especially if you happen to be in your 80s. We do have people in their 80s. Do you have any questions yourself, Leon?
No, like I say, I'm glad I have been able to chat. I wasn't able to before, but I'm glad I did get figure out how to chat. So that's great. And the information you sent me in regards to these emails for support.
Okay.
Yeah, I appreciate.
Well, welcome to group. We're happy to have you and give some serious consideration to getting a consultation such as the one that Rick sent you, so we can make sure that you're getting the right treatment.
Okay. All right.
Yeah, Dr. Jim will follow through with that. John, okay. You have two hands up.
The first one is Sam. Hi, Sam. Go ahead.
You need to unmute, Sam. Unmute.
I was saying that I'm 82. I'm a veteran. The best advice I could give you is keep going to these programs because they're invaluable.
Yes.
With all the reading that I do in healthcare, because I've been in healthcare for 50 years.
Oh, wow.
These groups have been fabulous in terms of identifying new information.
Great.
But the bottom line is read as much as you can, look into the disease as deeply as you can, and take control of your own future.
Absolutely. Thank you. Thanks.
Paul?
I would like more information about the pathology, which is a little uncertain with regard to the recent grade group because at the age of 80 plus, radiation therapy may be all that's necessary, or a short course of ADT is necessary. So, continued, we'll say, doublet therapy in your 80s really depends quite a bit on the biopsy Gleason grade group.
All right.
That's such a good point because you've kind of gone from potentially you've gone from maybe under treatment to over treatment. So the information that Paul is asking for will, plus the consultation that you're talking about, will help guide the way. Can you send your biopsy report to us?
I can go back and look and see what I can pull up.
Okay.
You know, that's really what was on my mind, Dr. Paul and Dr. John, when I'm thinking that it might be good to get a second opinion from Dr. Latenzi, who describes himself as being having a strong interest in GU cancers.
Well, if you can find something, Leon, let us know later in group or email it to one of us. There's some emails that you can send it to in the chat, okay?
Okay.
Welcome.
Thank you.
You're welcome. Glad to have you. Now, the next guy on my list is Bruce. I would, if I had done my homework properly, know a great deal about Bruce, but I haven't read all the information that he sent. But we're going to have him catch us up a little bit anyway, and maybe follow up next week after I've digested all the information. Bruce, do you want to tell us where you're at now?
Yeah. All of the things I heard with Steve, I had a similar situation. I guess I had what you call a non-typical diagnosis. Had annual PSAs, and none of them were ever above 3. In January of 25, I was having hip and pelvic pain and went to my primary care, and they did a bunch of tests and they recommended that I get a CT scan. When I got the CT scan, we have my charts at the hospital I went to. I saw the results, and they were basically diagnosing possible prostate cancer that had spread to my pelvis, my ribs, and my lymph nodes. So I immediately had consulted with the primary, and then I got into Cleveland Clinic and got an appointment with a wonderful, well, I'll call him a wonderful urologist, and he did a biopsy and confirmed it all, and also a PET scan. Immediately, the urologist gave me a 6-month shot of Lupron. So I started Lupron in February of 25, and I saw an MO at the Cleveland Clinic, and she put me on Zytiga and prednisone. I had an immediate reaction. I ended up in the hospital within a week to 10 days with anemia, and I should add I do have some heart issues. So, but the attending oncologist at the hospital I was at said he theorized that it was a Zetiga and suggested I get on Nabicwa. So within a couple of weeks, I was on Nabicwa and the Lupron. And once I switched to the Nabicwa, the edema cleared up pretty quick. And then in July of 25, I went on the triplet. I started chemo in July and finished it up in October. I had switched my oncologist from the one they assigned me at the Cleveland Clinic to a local one that was actually the on-call one when I was in a hospital in my hometown of Youngstown, Ohio. And the guy is very proactive. He is a small practice. Is just an MO with a number of prostate cancer patients. He's very proactive. I see him at least once a month. He likes to see me once a month. We usually do a PSA then, and I'm very pleased with him. And he recommended we get on Provenge. I actually just started that last week.
What did you start?
So,
Sorry, Provenge?
Provenge.
Provenge, okay.
Yeah. I've had one treatment, 2 to go. Those all went well. It went well. That's supposedly no side effects. My PSA has never crashed. The last two, one was 0.905 and the last one was 1.025. So I've never got down to undetectable. I've had a PET scan originally back in February of 25 and one at the end of the year of this year, December 25. There was good improvement on most everything. But,
Did you
it's
have
still
any
there.
metastases on those PET scans? Were the bones involved like you thought?
Yes, the bones, the
Yeah.
pelvic, the ribs, and lymph nodes. Nothing no organs though. And the second one in December showed improvement.
Good.
So I guess, and then also, I was diagnosed at a 4+4. Over the winter, I was in Florida and I went for a second opinion at Moffitt. They concurred with the treatment plan I was on, but they also looked at the biopsy and raised some of them to 9, 4+5. And I don't know if that matters much. It's pretty bad, but.
Okay.
Now, one other thing I did have, I had the promise genetic testing and nothing showed up there.
Okay. And you remember Rick said earlier in the meeting that when somebody's metastatic, the standard of care is to get gene testing not only the way Promise does it, but also to test your biopsy sample. Did that happen to get done?
I don't believe so. That's going to be my next request.
Okay.
Now, is that so I understand that that's the existing biopsy sample, or do you need to get a new biopsy?
They probably will use the existing biopsy sample because your metastases have now kind of shriveled up in response to your treatment, and there's not really a source of newer prostate cancer.
Okay. So I should request the somatic testing then.
Yes, I think so. So your current team then is who exactly is currently taking care of you?
Dr. Graham at Blood and Cancer Center in Youngstown, and my oncologist is Dr. Brian Canterbury at the Cleveland Clinic in Akron.
And is Dr. Canaveri a Janita?
Canterbury.
Oh, Canterbury.
Pardon me?
Sorry, Canterbury. Got it. Okay, so is
Yeah.
Dr. Canterbury in Akron? Is he a GU medical oncologist, Bruce?
No, he's not an oncologist. He's a urologist.
Oh, he's a
He's the one
urologist.
that did the
So do you,
biopsy and
right? Do you have a GU medical oncologist on
no,
your
I
team?
do not. They did
Okay,
not.
well,
Cleveland Clinic didn't assign me one, and I was not real happy with her. Then that's why I switched.
yeah, it's an issue. We actually don't refer to anybody. There are a couple of GU medical oncologists at Cleveland Clinic in Cleveland. But there are some other good people. I mean, we could come up with a name, I think, for you, either Case Western or I can look at
How
Cleveland
about
Clinic.
University? We also have University
Yeah,
Hospital.
but I always get confused. That's Seidman. Is that Seidman or is that St. Louis Seidman? I forget. It doesn't matter. We can come up with somebody in your area,
Okay.
but you really have to have somebody on your team. And are you getting emails from us?
Yeah, I got
Okay.
the email. I have
Perfect.
Jeff to thank for getting me in a meeting last week. I did attend it last week, but I got in late.
That's why.
But so
I'm
this
trying
is
to
I am a newbie somewhat.
Okay, you are a newbie, yes. All right. Well, I should be able to. Yes, I've got your email. I will think about when I write up your notes. I'll do a little bit of research, and we'll give you a couple of names that are hopefully relatively local. I mean, the furthest away, or it might be 6 of one, half a dozen of the other. How about Columbus?
I'm halfway between Pittsburgh and Cleveland, basically.
Okay, well, we've got a guy in Pittsburgh that we can send you to. We've got a guy in Columbus we can send you to, and we'll look and see who we can send you to, and I'll send you all of their names. And I think as much as you like your guy, you need to get on their books.
I need to do what?
Get on the books of somebody who specializes in prostate cancer.
Okay.
Yeah, you're a metastatic guy. You want to get the very best of care.
I didn't get that at the Cleveland Clinic. But, okay, I'm appreciate the help and look for the recommendations. And most of these people will see you. Or consult with you.
Yeah, most of them will. The ones usually who we send you to know us already, so they've worked with us through other patients. Certainly true of the guy in Pittsburgh. It's certainly true of the guy in Columbus. May not be true depending who we find in Cleveland, but we know other people in Cleveland. If there's a problem, we can get to them and we can smooth the passage.
Okay. Well, there's another possibility. Like I said, I spend two to 3 months in Florida. I did go to Moffitt and just had a general consult with them.
We wouldn't send you to Moffitt. We would send you to Dr. Guancial, who's in Sarasota.
Okay. Well, staying up in the Northeast would be better because that's where I spend most of my time.
Okay.
Dr. Jack has a comment.
Just a quick question. Bruce, how old are you?
74.
Okay. I just was wondering how you were tolerating so much treatment, triplet therapy. I heard the edema from the abiraterone but there's a lot. Did you have side effects? I mean, that's to handle
The
triplet
chemo, the
therapy.
worst thing was what I called it is chemo mouth and my nails. But I tolerated the chemo well, and other than the Antigua, everything else went pretty well, except my first dose of chemo from the Cleveland Clinic. I had a white cell count because they didn't do the what is that? They give you the shot
Neulasta.
one day after.
Neulasta.
Alaska, that's it. And then
Neulasta.
so the second dose went well, and that's when I changed oncologists.
Yeah. Hey, but Bruce, I thought you had hair before you started.
Actually, it came back. And I did lose a little hair, but I never lost it all.
I just have a last question for you,
This is
Bruce.
where most of it is, though. Facial hair.
A last question for you. You said you had heart problems. Could you catch us up on what's wrong with your heart?
Yeah, I had a heart attack, 3 stents in July of 24.
Okay. Are you?
So we're going to sign you up. We'll sign you up for, rather than getting into the heart right now, John. We'll sign you up for our heart list that John runs, ProsCard, and you and John can communicate. But we have a special list for guys with prostate cancer who also have heart issues.
Okay, and I do, I do exercise 3 to 4 days a week, so I try to keep that up also.
Good.
Good.
I will write to you. I will write to you after I've been through your data and send Rick a copy. Okay, Bruce?
Appreciate it. Thank you.
Yeah, you have one question there, Dr. John.
Steve Brennan.
Yeah, I think I may have missed that. John or Bruce, did you say that you had issues with edema at some point?
It was a side effect of his medication.
Yeah.
Okay, because I'm being treated for lymphedema. Which medication was it that caused you that issue, or did they think?
When I started the Zytiga in prednisone, within a week to 10 days, I blew up like a balloon, and actually ended up in the hospital for a few days, and they speculated that's what it was. We got off that and switched to Nabiqua.
Okay.
It's not a drug that you're on, Steve, but are you having a problem with edema?
Yeah, I am.
Oh.
So I thought it was that they don't really know why that I saw that it was a potential side effect of the docetaxel. I reached out to the Nubeqa folks and the Orgovyx, and they didn't think it was anything from them. So I was hoping it would clear my system, but it's lingered.
Yeah, I mean, we would say from here, given your drug history, that it's related to the chemotherapy.
Yeah, I think so too.
But it can take a while just to release. But your GP or your or Dr. Goldman should be working with you to help you with that. I mean, it's most likely we can't give medical advice. I would think it was, but we've got a bunch of doctors in there. Any of the doctors want to opine on that one, including Dr. John, or you already did?
It's got to have a physical exam and a workup for the many, many possible causes of peripheral edema. Okay, let's get on to some of our regular guys. Let's see, where is James Schreiber? James, can you put up your hand so I can find you?
Yep.
Oh, there he is. Okay. What you got on your mind, James?
Very quick, brief. September 25, I had a radical prostatectomy. At that point, they discovered that they didn't get it all. December of 25, my PSA was 0.38. So they proceeded to want me to go do some SRT. Had to wait for 7 weeks to get a PSMA test based on what you guys had recommended to me. So my oncologist agreed with that. So we waited for a PSMA that turned out to be negative. They couldn't find anything, which in the long run, I'm told is a good thing because there's not enough there.
James, let me just interrupt you a little bit. I want to make, Rick, do we have a information
Yes.
on James? Oh, we do?
Yes.
Okay. Okay, very good. Go ahead,
Yeah.
James. You don't have to go
Yeah, I would
over
just-
everything.
For other people who hadn't been on the very one I was on. But anyway, so PSMA turned up to be negative, and Dr. Carlin at the Fort Belvoir Medical Center, who's treating me right now, went through that, gave me some options to do SRT as well as ADT. What's interesting is that I did have the Decipher test done on my biopsy, which that information along with the PSMA, along with the other thing, they're finding that the ADT doesn't affect many certain types of genetics. And so I was in that category of, there was like a 3% difference between using ADT and not using ADT in the longevity. So I chose not to do the ADT. I am currently 5 radiation treatments into a 25 treatment regimen that Fort Belvoir is executing. I have absolutely 0 side effects right now, which I'm very happy about. And again, through this group was who pushed me to make sure we had a PSMA test. And also, I believe, Rick, you were the one that was pointing out the study that put that Decipher information overlaid with the other information that said sometimes ADT doesn't do anything. And my oncologist read through all that also and agreed with me that ADT was probably not going to do a whole lot to me other than the side effects. So that's where I'm at. Any questions, comments?
I wish I could remember what study I pointed you to, because I was trying to figure out, I wonder what his mutations are. Can anybody help me with that in the group?
I think it's the Arteria AI test that looked at one of the RTOG studies and was able to decipher in the unfavorable intermediate risk who would benefit and who wouldn't benefit from ADT. I mean, that's what it sounds like.
Yeah, I believe that's what it is. I can probably pull it up, but
yeah, I think I know what it is. It's one of the, I think it's one of those recent Kishan-Spratt meta-analyses things, isn't it? I think.
Yeah, Spratt was an author.
I mean, it's very recent. It was like February of this year.
Yeah, I think it was the Spratt study. I think now I know what we're thinking of. Great. I'm glad it helped you. I'm glad it helped you, Colonel. I mean, that's great. That's great.
Yeah, we'll wait and see. But the side effects of ADT with the less than 3% different. That's what they did. They overlaid all this Decipher data on top of a test group as well as a I just lost the term we use for the standard group. and found that those people who had certain genetic tendencies out of that Decipher test just weren't affected by ADT. It didn't change the outcome. So it didn't make a whole lot of sense for me to do the ADT if there was only a potential 2 to 3% chance of, increasing the effectiveness. So we'll wait and see what my PSE is in June, which will be when I'm done with my radiation.
Okay, thanks for the update. Any comments for James? Questions? Okay, Scott and Cindy, are you still here? Yes. Hi.
The wife's going to do the talking.
Okay.
All right, so just an update of where Scott is in his treatment. He got second opinions last week about his treatment, and the doctors we spoke to thought that we were in a good place, which is the gun study recommended to us. And since then, we actually had an appointment and we got the genomic test results, which showed that Scott had a TSC2 mutation in addition to the, what was the other mutation? The TP53. So we didn't know anything about that, but it was explained to us that it's in the AKT pathway, which I guess is similar to the PTEN mutation.
Yeah. Mm-hmm.
So we were told that there's an additional sub-study in the gun study that Scott would be going into, and they would be giving the CAPI.
Okay.
In addition to the Orgovix and the abiraterone.
That's very exciting, I think.
Yeah, agreed.
Yeah. So we just wanted to see if anybody has any, comments on it, and also if there are people in the group who have experience with this drug. I
doubt there's anyone here on capivasertib, but anybody comments, questions? Does AnCan have anybody on Capi, Rick, at all?
Not right now. We have in the past during the trial.
Yeah.
But it has had phenomenal results for P10. If in this AKT-mTOR pathway, I don't know how effective it is. I don't even know if it's downstream or upstream. I'm guessing it's downstream of the P10, but I'm not really sure. This is all a bit above my pay grade. Somebody else in here may know.
I thought Dr. Berg said it was upstream from it, but I'm not at all.
Okay, could be. Upstream and downstream, by the way, means whether the actionable pathway is before you get to the P10 gene or after the P10 gene. So the TSC happens before you get to the gene. So if it's upstream, it's possible that it is going to be effective. And of course, we hope it is effective. And yes, capivasertib has just been recommended to the FDA for approval in a recent ODAC meeting. And so it's likely to get approved very, very, very soon. It's called TrueCap, TRUQAP is the commercial name, and we'll be hearing a lot more about it because a lot of men with more advanced disease, something like 30%, have a somatic change in P10, and the more advanced you get, the more likely it is to show up. So we'll see. We hope you do really, really well with it.
Again, thanks, Rick.
I have the list of side effects in front of me now. Of course, you're going to get all that with your consent form, which you've probably already signed, but it looks like the chances of diarrhea are quite high. And so you should have a plan for if that happens. And you should keep track of your blood sugar, because that has a chance of increasing, and you have a chance of having rashes. They'll also do some blood tests, because some of these side effects are picked up on blood tests, and you might get tired.
Yeah,
Thank you, Doc.
those were all explained to us. So
Okay, yeah, sure. Okay, very good.
thank you.
Thanks, guys.
Thanks for the update. David.
Thank you, Dr. John.
My
All right, so
pleasure.
here's an
Nice to see
here's an
you again.
update. Had a PET scan yesterday at U of University of Chicago, and they found one met on my spine, and possibly another one. I'm getting confirmation down in a lymph node in my pelvic area. But let me give everybody a little bit of history. This is about monodera. I got off regular ADT in the end of 21. Was end of 21. A month later, I got on daralutamide with tamoxifen, and I was on it for a year and a half, and it kept my PSA down to 0. I took a drug holiday starting in about November of 23 until May of 25, and my PSA got as high as 0.7, 0.73. Found some Mets, 2 Mets on ribs, and had those blasted with SBRT. Got back on DARA in June of 25, and my PSA never came down back to 0. It came down as low as 0.09. Then Schmulowitz, I saw Schmulowitz. He did a PET scan. It was clean. He said, let's get off the DARA and let's see what happens. And then you'll take a 6-month break. So I got off about December 1st of 25. And my PSA between then and yesterday rose. It got as high as 1.15. It started off at 0.2, then 0.3, then 0.5, then 0.7. And yesterday it was 1.15. And so that's an update. And been thinking about Pluvicto and talking to Rick, and asked Schmulowitz yesterday, what about, SBRT, we can hit the one Met, both Mets, seeing what's there. And what about getting on Pluvicto and having more of a systemic approach? And Rick has told me about several trials, one at UFC called, what's that called, Rick? Media? No, I can't pronounce it all the time.
The one at UFC, which Schmulowitz discussed with you, is called PSMA-DC,
right,
which is Novartis. Sponsored trial at 137 locations. The one at UCLA with Keyshan is called Andromeda.
Keyshan, right. So that's an update. So looking for some input, and I'm all ears. And by the way, for Michael in Canada, the first time I was on DARA, I was on it with tamoxifen, and it didn't seem to help my gynecomastia, FYI. So looking for input. Thanks, Michael, and it was good talking with you last night.
So
it's a pleasure talking to you, Dave.
I just want to clarify, not clarify, I just want to fill out a little bit what David told us, because there is a possible issue. Not an issue, there's a discussion. So David's doubling time is pretty slow, and he clearly has oligometastatic disease. And right now we know that we can see something in L12, T12, and there may be some action around a lymph node, an iliac lymph node. Not sure if it's external or internal. So the idea of shooting that T12 lesion with SBRT and maybe adding something a little systemic, possibly like Pluvicto, is an interesting idea. And there are 2 trials out there right now that we know of, and there may be more. One of them is the one we talked about before, which I've written up in reminders. So if you search for Andromeda amongst the reminders, you'll find what we wrote about it. And that's a trial where it's only being conducted by Kishan, and what he's doing is shooting the lesion that he sees, or up to 4 lesions. So he'll take you with 4 lesions. It might be 5, but I think it's 4. And then giving you either 2 Pluvicto treatments, similar to the Pluvicto you'd get if you had whole Pluvicto, or actinium-225-1 treatment. And that's an alpha rather than a beta. And it's a little more focused, directed, doesn't spread out so far. And so he's looking to see which is the better one. And he thinks it's either 1 shot of actinium or 2 shots of lutetium. The one in Chicago, which is at 137 locations worldwide and sponsored by Novartis, is very similar. They will treat the lesion that they see, but they also give you 4 shots of Pluvicto, not 2, 4. And Dr. Schmulowitz said to Dave yesterday, the problem is I don't know how many we could give you. I could give you the Pluvicto, but we don't know how many to give you. So that's sort of where he left it with David and Dr. Schmulowitz left it. But I'm encouraging Schmulowitz to look a little deeper and to think about, and of course, Schmulowitz thinks there could be side effects from 4 Pluvictos. But what about 2 Pluvictos? And since we know that that's bona fide, Len, you have your hand up, so I'm gonna hand it over to you, and then we'll go to Dr. Wassersug.
Okay, thanks, Rick. I was just listening to you talk about the doctor saying we don't know when to stop the RLT. Well, how about just monitoring his response? If he gets 2 cycles of either Pluvicto or actinium, and the PSA is down to almost nothing, you could stop there. That's a good place to stop, I would think, right? The other thing I wanted to ask David, 2 things. Do you recall what the SUVs were on your PSMA PET?
I don't, Len.
Okay.
Maybe it'll tell me. Let me take a quick look.
Yeah, because of course that, playing the long game, clinical trial from the NCI would probably argue if your SUVs are low and you have relatively slow doubling time, maybe you don't need to do anything. And the other thing I wanted to ask you is, have you had any symptoms while your PSA was rising? Any symptoms at all? Nothing?
0.
Okay.
Feel great.
Yeah. Yeah, I asked because I've been on a 16-month darolutamide holiday, and my PSA is just 0.07. And I'm going to have Dr. O just scheduled a CT scan for me just to see if there's any radiographic progression, even though the PSA is pretty stable. So, and I have no symptoms, so I was wondering if you had any.
No symptoms, feeling amazing. Matter of fact, it's like I forget I have cancer. Feels so good.
Yeah, right.
And you know, the benefit, if people are wondering, well, why doesn't he just go back on darolutamide or darolutamide and Orgovix or whatever it is? Why do you, if you're thinking, I mean, the whole point here is we're trying to do something else which is systemic that doesn't require you to be on hormone therapy, because I don't think there's anybody in this room right now who would say they'd voluntarily like to be on hormone therapy if there's another alternative.
Sounds like a perfect time to ask Dr. Wassersug to speak. Hi, Rick.
Let me answer Len's question. I think the SUV was 5.2.
Say that again?
5.2 on the SUV.
See, I think that's pretty low. That doesn't sound like something I'd worry about.
What was the SUV in the liver?
Never had anything in the liver.
They usually give you some kind of what your baseline or background SUV counts are. Like it's usually maybe about 3 or so. See anything about that? Sometimes they say liver, sometimes I think they'll say blood.
Let me see.
Might be at the top of the report.
Pressure.
John, may I comment and ask a couple of questions to David?
Yeah, let me just I'm going to just give David a couple more seconds to find that SUV so we can put this question to bed, whether he could be considered for no treatment.
I can't find it.
Find it. Okay, go ahead, Rich.
So David, I mean, you've got various concerns in terms of treatment. You said two things, that you're taking tamoxifen presumably to prevent gynecomastia, and that it didn't seem to be working. But then you said you had no symptoms. So what is the nature of the gynecomastia that you had experienced? And I'm very much particularly interested in this because we talked about Rick saying nobody would want to be on hormonal therapy. I've been on hormonal therapy for almost 25 years, and I would rather stay on what I'm on now than go for anything else because it controls my cancer. But I'm on high dose estrogen, so the gynecomastia issue is a real one. So did you request to go on tamoxifen, or were you told to go on tamoxifen? And how is it working, and what are the symptoms you're experiencing?
So the tamoxifen was on my first round of Darrow. And I got to tell you something, I don't remember because it was back in 23. I assume that Dr. Schmier told me to take the tamoxifen, or maybe I started taking it after I started getting gynecomastia. I don't remember. I know that's your specialty, Richard, and I don't recall the details. I'm sorry.
So are you having?
Oh, I have them. I have some details here, David, in my notes that you started that back in I'm trying to see when you started, but in August of 22, you were having issues, and Schmulowitz said, let's try, here are the alternatives, and you can do surgery or you can do tamoxifen. And you spoke to a bunch of guys and decided that you were going to do 10 milligrams of tamoxifen.
There you go, Richard.
And what happened was that it didn't work.
Correct.
And so I'm not sure.
Hold on a second. When it didn't work in terms of nipple sensitivity or breast development or both?
Breast development.
So you have large breasts now, like as large as mine?
No. Hold on a minute, Dr. Rod. We're not done.
There's a story here. Keep going.
We're not done. I know you want to know about this gynecomastia, but we're going to get there. I cannot remember if you ever had radiation. Did you have radiation after the tamoxifen? No, you never did.
No.
And then David decided he was going to do surgery. And when did you? I'm trying to see when you did the surgery, but you did the surgery. But that didn't help. It certainly helped cosmetically, but then it started coming back again, right, David?
That's right. It came back. I had it done. The surgery was great. I got back. I had the surgery in January of 25. Got back on Dara in July of 25, and my breast grew. But I got to tell you, I think after I got off the Dara, I think they've come down a little bit in size.
Okay, so you had the surgery for nipple sensitivity or breast reduction in size?
Breast reduction.
So how large did it get? How bad was it?
You know, I don't have a measurement for you. I can just show you by, you know, it would fill my hand.
So I just want to say that there's some concern about the tamoxifen. For instance, in the patch study, which is a high dose estrogen trial, they did not allow it because it did work for reducing the breast, but the hot flashes came up. It added hot flashes, and it doesn't denies you the protection of a high dose estrogen, which you would have gotten because you're on a monotherapy for a diandrogen. It would not give you the protection of bone density. So in general, there's a case against it. I'm just curious as to whether this was discussed with you.
Well, but I think it's a good point, Richard. But I think it's water under the bridge right now. Okay. And when people bring up tamoxifen, we make that point and we have them go back and make sure that it gets explained. In David's case, I don't think there's a point in discussing the downside of tamoxifen because he's well beyond that.
Other comments for David?
Let me ask you a question, David. You had a bilateral mastectomy. They took out the breast tissue and it grew back?
Yeah, but I don't think he took out all the breast tissue. It was more of a cosmetic thing than it was like a double mastectomy, Jack. Oh. That's what I believe because my breast grew back. And I actually went to see my my radiation guy because I wanted to have radiation done. He was afraid to touch me because he didn't know how much tissue was really left, and he didn't want to hurt me.
It's confusing.
Yeah, but I've let the whole breast thing go for now.
Paul Schellhammer has his hands up. He may have some more
to say. Go ahead,
say.
Paul. You're muted, Paul.
Thank you. It is confusing. And I agree, David, for you, it's water under the bridge. But I will have to say that whoever did the procedure on you was a minimalist. And having had a breast reduction myself, I mean, the tissue that responds to estrogen, the mammary glands, of which in the male is not a big volume, but it can be encompassed rather easily and readily, and then you don't have anything there to respond to monotherapy with one of the ARIs, which pumps up your estrogen because you have a very high T that then gets aromatized to E. So, this with monotherapy, it's going to become a bigger issue, gentlemen, gynecomastia that is. And if you see someone that have a breast reduction, it shouldn't be a minimalist when they're there. Take out the mammary tissue and be done with it. Not my contribution.
Get a mastectomy, a simple mastectomy rather than a partial.
Yes.
I was
great advice
about going back to the surgeon and talking to him about it, but I just didn't feel like going through the surgery. But maybe I should consider it before I get back on Dara.
Go ahead, Michael. Unmute yourself.
Just a quick comment. I was reviewed last week. I'm on Monodaro, and I took a vacation in January, and my gynecomastia after 6 weeks did subside considerably. So it's probably a side effect of taking the drug, but if you're off the drug, it does go away.
That's good to know. I didn't really think it would subside much after.
Yeah, the nipples start to harden again. When I'm taking it, my experience is that the Darrow causes the nipples to basically inflate, and the breast tissue becomes tender. But when you're off the Darrow, within about 3 or 4 weeks, everything seems to go back to normal. I suspect that had I stayed off Darrow, it would have gone all the way back to normal, but my PSA rose, so I had to get back onto Darrow.
Go ahead, Rich, and then Jack.
Just in the literature, there's two parts to this. There's the mastinea or mastalgia, which is the sensitivity of the nipples, and then there's the breast volume. And when you're talking about it, was it the sensitivity of the nipples, or the breast volume, or both that were bothersome for you, Michael?
Both were bothersome. The breast nipples become the sensitivity issue because they become. I look like a 14-year-old girl, and then the volume kind of grows with it. But it's more the sensitivity that bothers me because the nipples aren't normal size.
Yeah, so nipples then. That's
Yeah.
where Dr. Schellhammer and I and others in this estradiol initiative are looking into how extensive are these issues with estradiol, because it is these monotherapies, as Dr. Schellhammer pointed out, of the second generation anti-androgens that lead to elevation of estrogen, because you have all that extra testosterone floating around that can be aromatized. So we'll be hopefully publishing this relatively soon, but we're finding that it appears to be actually the nipple sensitivity that is most stressful, and that was my situation. The amount
I would agree with that 100%.
Thank you.
And I have a question for you, Dr. Richard, and also Dr. Paul. Have you heard or read that this reversal when you go off of the monotherapy is common?
Yeah.
Or
well, I can answer because we have a paper manuscript that's in revision, and the reviewer asked that very question, and Paul flipped it to me about 2 days ago, and I didn't know the answer, but I think we can refer to anecdotally what I've learned today. So thank you. This is the first I've heard of this, but even though it's a small sample size and anecdotal, it's nice to know that. Paul, would you add?
Well, we've got two. Anybody else is there anyone else in the room who's been on monotherapy, ARSI, darolutamide or otherwise, that has experience in the room today? Dennis,
Rick, a quick.
Dennis, go first, and then we'll go to Jack.
Well, I'm on mono now with Darrow, and my actual gynecomastia seemed to, and the nipple sensitivity seemed to go down. Prior to this, I was with Eligard and Darrow. That's when I had the biggest problem. And when I got off the Eligard to take a break, I had no more sensitivity in the nipples, just the opposite of what you've been saying. That's my experience.
Kind of counterintuitive. Jack?
I just have two questions for Dr. Paul. One, how difficult a procedure is this bilateral good mastectomy where they clean out all the breast tissue? How difficult was that for you? Is it relatively simple in and out, or is there some trauma associated with that?
It was straightforward. It was an outpatient procedure. I was there at 8 and home at noon. I had a pressure dressing and a drain, and it was very reasonable. And maybe I had a 1 or 2 Percodan at the time, but I cannot recall it being significant. So I think it's pretty straightforward. And the other thing is, for those of you who are having nipple sensitivity, the topical NSAID, diclofenac, which many of us use to rub on our knees and ankles and elbows, has been shown to be effective to ease the burning and discomfort from nipple sensitivity. Very straightforward, very inexpensive, and quite harmless.
It's good to know. My second question to Richard, what is it that stopped you from getting the mastectomy? You just kept letting your breast grow for the past 22 years. How come you didn't get a mastectomy like Dr. Paul?
Because first of all, concern about the mastectomy appears to be age dependent. We just published that. That is, older guys are seem to be less bothered. That's in a paper that just came out of Canadian Journal of Urology, buried in there. And secondly, it's minor and it's self-limiting. And I didn't think as with women who are going through puberty, the nipple sensitivity and the discomfort can be great, but it's self-limiting. So my breasts have not continued to grow. I have about 8 cup size, and it's inconsequential. So what I feel is not being done is that the clinicians say, oh, you go on this drug treatment, you're going to get gynecomastia. That's the wrong question. The right question would be to say how much gynecomastia. And the data we have in the paper we're working on revising now is that it actually turns out to be remarkably minor. It's cup A in breast size or smaller. So that should be something that should have been in the discussions, I think. Not you've got to get breast, because most of us think you're going to get breast, you're going to get breast that might be attractive to me when I was a teenager or whatever, younger. But that's not the data do not show that is actually what happens. So,
okay, guys, I'm gonna keep moving because we got 3 guys to go. Let me get to Sam, and then I'll get to our last 3 guys.
I was on Orlita and Ergovix for 12 months and have now been off of it for 18 months. And I vaguely remember some nipple tenderness, but it's completely gone away. And whatever gynecomastia I had, it's less than what I had during the course of treatment. So my opinion is that once the treatment stops, at least for me, it went away pretty good. And frankly, I was kind of surprised that it was so troublesome for some people that they went and had the surgery.
Okay, I'm going to move to John McPhee. John, are you still here?
Yep, I'm here.
Good, hi.
2 questions. One is, by and large, I'm on Zoladex and Erlita. I'm 9 months into it. I'm doing great. Most times this does not get in the way of life. But like today, I had a weight workout and I pushed out hard. And it just sucks the energy out of me and I'm flat. I mean, it's all I can do not to have a nap. Should I be giving in and having a nap during the day or?
Yes. Yes.
Wow, that sucks the heart right out of the day.
Generally speaking, even though we feel like resting when we're fatigued, resting generally doesn't help very much. You're better off going for a walk. But you've exercised already, and now you're fatigued and you need to recover a little bit. And so in that regard, that's why Rick says, sure, you've done your exercise, give yourself a chance to recover. And then you'll be ready to go again. Yeah. But so in other words, don't nap instead of exercise. But sure, take a rest after you exercise a little bit.
John, I exercised literally every day when I was on home. I was only on singlet at the time because they didn't, the doublet wasn't the protocol back then. But I'd go down to the rowing club, I'd do my workout on land or on the water, and I'd come back, and then I would nap almost every day for 20 minutes or 30 minutes, but that was all. So I set the alarm, and then I'd get up and I'd feel great.
Okay. All right, I'll give that a try.
Was that your only question, John?
The second question, and I know it was answered already, but I can't remember what the answer was. So I'm 9 months in. Am I going to be on this for forever, or will I be able to go off? And if I am, at what time, after a year and a half, 2 years? I remember Rick being pretty adamant that you needed to stay on for at least some magic number.
Well, you were a Gleason 8, and we don't know about any metastases or abnormal pathology about you. At least I don't.
Oh, I have two metastases, one on my trachea and one on my tube to swallow with.
Okay, and that Gleason 8, you didn't have any intraductal or cribriform disease? You had
No
regular
idea.
What's that?
No idea. My doubling time when it now with reoccurrence was 2.4 months. So I think it was fairly aggressive.
Okay, okay, metastatic. So, and you couldn't get those metastases radiated.
No.
Doublet. So you're on doublet now for 6 months so far?
9 months so far.
9 months so far?
And doing okay. You know, like when I was on Lupron before. Lupron, I just kept getting weaker and weaker and weaker, and it didn't matter about working out or anything. It just was miserable.
And now you're on Lupron plus what?
Well, Zoladex plus Erlita.
Okay. And who's your oncologist?
Oh, Peter Chung at U of T and University Health Network.
Okay.
Yeah, he's a radiation oncologist, John. I just sent you my notes. So
okay, so traditionally, traditionally you might have been on for 2 years with this kind of a history. Now, we're starting to wonder. Any comments, anybody?
I mean, look, we anecdotally, because we can't tell you, and the thinking has definitely changed. I mean, I would say you could have been on for 30 months, even 36, because you had these strange soft tissue metastases. What we've seen anecdotally is that the guys who come off much earlier than 18 months usually have issues. Now there's exceptions like Jimmy, who's here in the room right now. Oh look, he lifted his head. You heard his name. And he managed well. He's done fine with 15 months. But I think that if you don't do the time, you run a risk. I mean, I always think of a very dear friend of mine, of AnCan's, who was diagnosed shortly after me. He had 4+3, but he had seminal vesicle invasion, and he had very similar treatment to me. And he only did 6 months because he couldn't tolerate it, and he had a high-level executive job. His disease came back, he did chemo, and he's not with us anymore. And I think that, now, when I say things have changed, that recent paper that we referred to earlier on today by Spratt, Dan Spratt and Kishan, they say in most cases 12 months is sufficient, but if you've got T3, T4, yes, you may have to go out longer. So they don't rule it out, and they accept a longer period of whatever hormone therapy you're on. But I would say try and tough it out for at least 18 months before you have the discussion. That's what I would do.
I have one thing. Yeah, this is of course our bias, my bias. you might ask if you could shift over to transdermal estradiol and have that discussion with the doctor, because the side effects are so much more manageable, and then you're going to get a good enough testosterone. You'll get comparable testosterone control that you're going to get with Lupron or Zoladex, but with a lot less side effects.
So, Richard, this is a very, very appropriate comment, because John's being treated at Princess Margaret. How is that going to be received in Canada?
Depends on where you are. We know that if you're at McMaster, we know some people who will prescribe it. I have not talked to all of the docs in Toronto that provide it. I think if you go in with the right papers, I mean, you're welcome to contact me. You don't come in with a big argument. You come in with just 2 papers and you say, could we try this? One of them was from the New England Journal of Medicine by Langley et al. From 2 months ago. And one of them was a paper that Paul and I just got out, as I said, on the side effects and patients' interest in managing the side effects of ADT for various drugs. And you say, you ask, could I try this? And have a discussion. I don't know, Paul, you're muted, but you want to add anything to that?
No, I think your hormone therapy for you is important for your disease control. And if you can stay on it longer because it's easier, then that seems to be a natural pathway to take. You get the benefit and you don't get the beating.
Richard, why don't you keep the floor and tell us what's going on with you, your recent paper, anything you want to bring up?
Okay, well, I think I've already made the case.
Okay.
Paul Schmier and I and several other people have formed the Estradiol Initiative. If you're not aware of it, it's as if it were one word, estradiolinitiative.org. And a big question that's coming up is, what doses could I use from the patients? And does it matter whether it's this brand of patch or that brand of gel? And we have on the website frequently asked questions from the doctors, because we're getting them. I don't know how to prescribe it. It's on our website. From the patients, I don't know whether I should add more or less. We're getting those questions every week. But the information is there. We invite you to look at it. And I can speak I think for both Paul and myself, both of us coincidentally have been using high dose transdermal estradiol for our own ADT for both of us. Well, Paul almost 20 years, me over 20 years. No cognitive impairment, no hot flashes, no evidence of osteoporosis, no sign of fatigue. In fact, I feel so normal on it. And my comment on that, my personal comment is, campaigning here, that the human brain is better on any gonadal hormone, estrogen or testosterone, than on none. And of course, all of the drugs like the LHRH drugs and agonists and antagonists crash all your testosterone and all your estrogen. So I invite you to look it up, and you can contact me, just richard.wassersug at UBC, at UBC for University of British Columbia.ca if you have questions about it. But take a look at the website. And we're inviting patients to ask the doctors about it. They're not required to prescribe it. It's still off label. We have applied to NCCN to have it approved. But at this point, it's off label, and it's not inappropriate to ask, but please don't badger the doctor. Just bring it up as an option for discussion. That's my comment.
Thank you, Richard. Pierre, can you stay a little bit over time and tell us what's on your mind?
Just wanted to give you an update since I last presented. At that point, I was trying to decide between triplet and doublet therapy.
Okay.
So you recommended that I get a third opinion with Dr. Atish Chaudhary at Dana-Farber. So that took place on May 1st. Prior to seeing him, I did start the doublet on March 28th, and my PSA at that time was 4.33. Repeat PSA 4 weeks later was down to 0.11, and I'm due for another one next week. Dr. Chaudhary agreed with the doublet rather than triplet at this point. The only comment he had, I had the Guardant 360 somatic, and that came back not showing much tumor pickup. So the way I look at it, it's almost an equivocal test. I mean, it's negative, but some of the things they looked for, they couldn't determine because they didn't have enough tumor cells. So he suggested that I have somatic testing on the prostate tissue. And Dr. Levine at Roswell agreed with that. So that got sent out a couple of days ago. It'll probably take a month like the Guardant did to come back. So at this point, the plan is doublet for the foreseeable future, and then radiation in addition to that for the cytotoxic potential, basically. And I just got to decide when and where I'm going to do the radiation. I'm trying to work it around plans that I had this coming summer, so I may not do radiation till fall.
Well, we wanted you to get going, and you certainly did. So I'm really glad to hear all that. Go ahead, Rick.
Where will you do the radiation, Dr. Pierre? Have you decided?
Well, I considered, I spoke to the radiation oncologist at the Mayo, but logistically, and I liked him, but logistically, that's difficult. You had suggested Dr. Pratt, I think, at Case Western. My plan was I have a fifth wheel that I live in during the winter when I'm out in Arizona, and I was going to bring it back east, but campsites around Cleveland are hard to come by. You basically almost have to drive an hour and a half to get into the city, so that kind of defeats the purpose. I checked into Rochester because the guy that I spoke with at the Mayo, some of his residency mates were in Rochester. Well, one's in Rochester and one's at Case Western. And so he gave me their names. So I contacted Rochester, and they're swamped because the local radiology center here in my hometown closed down for 6 months. So the patients all scattered to the nearest facilities, and one of them was Rochester and the other one's Buffalo.
Let me just interrupt you a second. So I think it's Dr. Byland at Rochester, and he gets really good grades from us.
Byland.
We've had a couple of people who have gone to him. I can think of 3 people. And we'd be happy to reach out to those people that went out and see if they can get you in if that's where you decide you want to go.
Yeah, I have an appointment with the medical oncologist next Friday, and they were able to coordinate the radiation oncologist seeing me the same day in Buffalo. So I'm at least going to talk to him again and see if he would, do the same type of radiation that the one at the Mayo was going to do. And maybe you guys can comment on this. My Mets reoccurred in the lymph nodes, at the rim of the pelvis and the retroperitoneum, and then maybe 2 ribs. SUVs were pretty low except for one lymph node, which was 7 point something. The rest of them were 4 or less. I'm leery of having the prostate bed irradiated, thinking that if I'm going to get side effects, that's where they're going to come from. They're going to hit the bladder or the rectum. I'm more inclined to say, hit what we know is there, the lymph nodes in the pelvis and the retroperitoneum, and plus or minus the ribs. Am I off base with that, or is that something reasonable?
Well, I mean, my thought is this, and of course, I didn't have surgery first. I only had radiation. But if we know that there are issues already in some of the lymph nodes, and you have it's already gotten out, and you were upgraded to a Gleason 9 with your with your, do you recall if that was a 4+5 or a 5+4?
5+4 cavernous and intraductal.
Right. So the chances are that it's all over your pelvis. It's right across your pelvis. So if you're going to go for radiation and you don't cover the whole of the pelvic area, the pelvic girdle side to side, I don't think it's going to. I don't think it would have the effect. I wouldn't do that if I was a 5+4 IDC and et cetera, et cetera, et cetera. So I would say if you're going to have the radiation, you got to go for the whole area.
Personally, I'm also uncomfortable with sparing the prostate.
The prostate bed. The prostate's gone, and
prostate bed, yes.
Yeah. Yeah, I mean, so far, all the Mets are on the right side, which is where, most of the tumor was. And the last PET scan that showed those Mets hasn't shown.
The problem is, and Mark Perlow made this point last night in the low intermediate group. What we see is what shows up. We don't see everything.
Right.
People, people think, oh yeah, it's image, so I've got it here, but we don't know where else it is. We only know that it's where it shows up, but it could be in a lot of other places. Right. Did you discuss discuss the extent of the field with Dr. Atish? What would he suggest?
He didn't go into specifics, but he agreed that radiation to the retroperitoneum on the right and, the pelvis, was what he thought his radiation oncologist would recommend. He also mentioned considering going off the Orgovyx and just staying with the Abbey 6 or 9 months into it. And I wasn't sure why. I don't know if it's a cost thing or,
No, it's because he thinks you're going to do much better on monotherapy abiraterone than on the doublet therapy. And it's the sort of thing, it's the reason why we like Dr. Atish. He's thinking about you and how you do best. By the way, did you like him? Did you have a good concert?
Yeah, no, he was a nice guy, and my wife and I saw him, and he spent well over an hour with me. So yeah, and answered all my questions. So I have have a lot of respect for him. And
he said it because he figures you're better off on a monotherapy and keeping that testosterone in your body, although you've heard some of the issues around that today,
right.
Than you are on a doublet therapy. And he's always had a long commitment, a real commitment to quality of life.
Mm-hmm.
And that's again why he's one of our favorite docs.
Yeah, I guess I'll cross that bridge, when I'm 9 months into it or whatever. Because right now, other than hot or manageable, I'm tolerating the doublet, no problem. So that's the latest from me.
Okay.
Can I give an update, Jim? Rick?
Just, Leon, if you could just put it in the chat, because we're really pushed and I don't know how many more guys we've got.
I'm out.
Yes.
Oh, you're out. Then yes, please go ahead, Leon.
3. You had asked about the biopsy earlier in regards to the Gleason score?
Yes.
Okay, let me give it to you right quick for the group. My Gleason was 4+4. Right base, right mid was 4+3. Right apex was 4+3. Nothing on the left side. Everything was on the right side.
Okay, so you are 4+4. You're a 4+4, Leon. You take the worst one.
That makes sense now.
Thank you.
I just wanted to give you an update on that since you gave me that opportunity. I appreciate it. Thank you very much.
Thank you. I want to Frank, give me a wave first of all. I know you're awake. I can see you looking at me.
Okay, what's
here.
up?
I haven't looked at your foundation medicine yet. I didn't have time before the meeting. What did it say? I'm anxious to know.
I don't know. We don't really know what it says. We're gonna go to the doctor tomorrow. We got an appointment for my
Okay,
tomorrow.
I'll look at it tonight. Lisa, you can't really tell what was in there?
Well, I could see, I mean, he does have the ATM gene. He had the, I mean, it just showed up a whole list of things that he hadn't had before. So, and I'm not,
right.
We just got it today. So,
right. And this is the reason why exactly the reason why I wanted him to get it, because I figured there would be a whole bunch of stuff, but I'll look at it later. It came in, I didn't look. I'll look at it. I'll send it to John and Len, and we'll get what time's your meeting?
We see them. We go to tomorrow at 7 a.m.
What time? 8 a.m.
7 a.m.
7 a.m. 7 a.m. All right, I gotta look at that tonight. So I will look at it and get back to you. Okay.
All right. Thank you so much.
All right.
Okay, everybody, we're a little bit over time. I think might be a group at the half hour. I'm going to close things up unless there's any questions or urgent matters.
I don't think so. Anybody got anything? Did we miss anybody? Do we need to come back? Is there anybody who needs priority next week because they didn't get in this week? Don't see anyone, Dr. John.
Very good. I'm going to stop the recording.
Great job.
I will see everybody next Monday.
Okay.